Good evening. I'm Dr. Prasad, Consultant Emergency Medicine at Hyderabad City, Hyderabad. So I'm very delighted to welcome you all for the webinar series that we conduct every Friday. So today we have a renowned speaker, Head of the Department of Emergency Medicine, AIMS partner, Dr. Bhushan sir. So he'll be uh, taking you through the presentations of cardiogenic shock, which is a very common presentation in the emergency department. So I welcome you to the webinar, sir.
Yeah, thank you, Dr. Prashad. So, can we start? Can we start? Start?
Yes,
Is it okay? Am I
yes,
audible?
sir. We are live, sir.
Okay.
Yes, sir.
So, किसी को आने नहीं देना. So, cardiogenic shock in emergency medicine is something which is day in and out. We see these type of patients, and many times it got confused with acute exacerbation of COPD. Pulmonary, it is found with the pulmonary edema. So it is something which is very common in the ED, and many times it got confused with those differential diagnoses. It is important to look and find out the patients with cardiogenic shock, because if we identify that person is in the cardiogenic shock, the treatment is altogether thought it is a little bit different, and it tells about the prognosis of the patient too. So it is dictated that the most chronic heart disease is caused by having greediness in your heart. So it is ultimately it is due to the lifestyle of ours in day-to-day life, and we have to go for the checkup regularly and learn how to swallow those lumpy pills of generosity, be kind and be healthy. So yes, a good lifestyle and regular medication for those who are on the having some diseases like diabetes, hypertension. These are the most of the time these are the culprit behind the cardiogenic shock. So let's move towards the cardiogenic shock. What is the definition? So, cardiogenic shock is a complex, heterogeneous, multifactorial syndrome in which a cardiac disorder results in insufficient cardiac output, culminating in end organ hyperperfusion. So, what the important thing here is to note is that there is insufficient cardiac output. The heart, what the blood it is pumping, is insufficient to meet the organ demand of kidneys, liver, of brain. So if somebody is having low cardiac output, it will cause dysfunction of these organs too. The short-term mortality of a person who is having cardiogenic shock, it is around 30 to 40%, and in a year, if we look into it, the mortality is around 50%. As we know, the most important cause of cardiogenic shock is acute MI. Besides MI, there are various other causes of cardiogenic shock. But let's see, as a in emergency perspective, as an emergency physician perspective, when we think about if the person is in the cardiogenic shock, does the hypertension means cardiogenic shock? Does the low cardiac index is said to be a cardiogenic shock? Or high pulmonary capillary wedge pressure is known for is recommended to know that that person is in the cardiogenic shock? Or hypoperfusion? So there are hypotension we can check in the ED, but low cardiac index in the high pulmonary capillary wedge pressure, it needs cath lab. Hypoperfusion, yes, we can detect it in the ED. So these are the things, hypoperfusion and hypotension. These are the two clinical things where we can suspect that person may be in the cardiogenic shock. So what can we predict? Can we decide our treatment uh, by seeing just the patient? As the emergency physicians, what we have in our hand, we have our clinical acumen, stethoscope, and now the new stethoscope of the emergency physician, that is the ultrasound. But by seeing the peripheries of the patient, by palpating the pulse, what we can decide? We can decide the peripheries are warm or dry. So there are we have divided it into the cardiogenic shock into the four categories. The first is warm and dry. Dry and wet means pulmonary thing. That is the pulmonary edema plus or pulmonary edema is not there. So dry, there is no pulmonary edema. In warm means the patients, the periphery is their circulation in the periphery is good, so the systemic vascular resistance is low. And in warm and wet, that is the decrease in the systemic vascular resistance, and wet means there is an increase in the pulmonary capillary wedge pressure. The person is in the pulmonary edema due to the cardiogenic shock. Cold and dry, where the systemic vascular resistance is high, and there is a dry means there is a decrease in the pulmonary capillary wedge pressure. Cold and wet, that is that there is an increase in the systemic vascular resistance and increase in the pulmonary capillary wedge pressure. So which group is the worst one? The group which is worst, having worst prognosis, is cold and wet. Those persons who have high vascular systemic vascular resistance, their peripheries are cold and chest is full of crepes. So cardiogenic shock along with the pulmonary edema, yes, it is the worst prognosis. It carries the mortality of around 51%, and that those who are warm and dry, they have the best prognosis of around, they have mortality of around 10%, less than 10%. Now this is the stages. Now we have to confine us about the stages of the cardiogenic shock. It is defined by the SCAI, that is International Society of Cardiology. They divided the cardiogenic shock into the 5 categories: A, B, C, D, E. In the A group, the A group says that the person are in the at risk of the cardiogenic shock. So they can have diabetes, they can have high blood pressure, but the person is not frankly in the cardiogenic shock. The physical examinations will be normal. There is no high in the GFP. Perfusion is normal. Distal pulses are strong. Lactate is normal. Renal functions are normal. Having good systemic systolic blood pressure. Creatinine clearance is okay. CVP is normal, and saturation is also more than 65. When the person land up into the category B, this is the person when the clinical evidence of hemodynamic instability or hypoperfusion, GVP raised up, perfusion warm and well, and distal pulses are strong. Lung sounds can be seen. We can found the clefts, and on ultrasound we can found the findings depending upon of pulmonary edema. Lactate level is still normal. The renal functions are minimally compromised, and BNP rises. The blood pressure decreases to 90, and MAP decreases to 60, and heart rate goes up to the more than 100. When the patient land up into the category stage C, there is a stage of hyperperfusion requiring intervention, that is pharmacological treatment or mechanical treatment beyond volume resuscitation. The GVP is high. They started the organ have become dysfunctioning. Now the mental state has become obtended. Distal pulses are cold and climbing. Lung sounds, there will be extensive rails. Urine output decreases. Lactate increases more than 2. LFT increases due to ischemic hepatitis. BNP elevated more. SBP and the MAP decreases. And the cardiac index also fall down less than 2.2, and capillary wedge pressure is increasing more than 15. When the person condition deteriorate more and land up in the stage D, it is a failure to initial support strategy to restore the perfusion. We have started the treatment, but they are not responding. Any stage C and worsening in the hypoperfusion, the lactate is still rising and the renal function is still compromising. LFT is still worsening, and we have to what we have to see that it requires escalating of the doses of the uh, uh, Inotropes, and we can need the mechanical cardiac support devices to maintain the perfusion. In stage E, there is acute or impending cardiac collapse. Person is unconscious, pulse rate is near pulseless, cardiac collapse, multiple defibrillations can occur, lactate rose more than 8, person may land up in the CPR, and there is a marked acidosis of pH less than 7. So these required despite mechanical profound hypotension is there. So these are the stages when we should try to classify our patients in the stages of the patient, so that will give us the clear cut indications of when to start the treatment or when to observe them closely So these stages are very important in a clinical practice. So when we think about cardiogenic shock, that we have discussed that when there is a perfusion mismatch, there is a sustained hypotension, congestion, there is crepes in the chest, there is decrease in the urine output, and symptoms like shortness of breath. These occur. The increase in the JVP. We have to suspect cardiogenic shock for one or the other reasons. Now, as I have told you that the important thing along with the stethoscope and the clinical acumen, the new stethoscope of the emergency physician, that is the rush ultrasound. In ultrasound, we do the rush protocol and for the hypotension, and to rule out the other emergencies like pericardial effusion, right ventricular dysfunction, left ventricular dysfunction, and uh, on any obstructive hypertension like heart, we have to look IVC, we have to look for Morrison's pouch or aorta or pulmonary. So all these things can be delineated by the rush protocol. This is a good tool where we can find the patient of cardiogenic shock and we can treat them promptly. So these are the things which we can see in the rush protocol in the patient of cardiogenic shock, poor LV function. A plump IVC of more than 2 centimeter does not change more than 50% of percent, and more than 3 B lines in more than 2 areas of the chest. Pleural effusion, peritoneal fluid or RB is the size of the RB is more than two-thirds of the LV. So what we do in the ED? So in the ED, the best part when we start with the primary survey and then secondary survey, we look for the ABC, airway, breathing, and circulation. When we see airway and breathing and the patient is having respiratory distress, if the respiratory rate is more than 25 and the SpO2 is still less than 90, we have to supplement with the oxygen, and NIV is the best thing. What NIV do? NIV give a pressure to open the alveoli. It gives the pressure and this transfer the patient from the fluid from the intra-alveolar to the interstitium and then back to the circulation. So it give a positive pressure and it symptomatically relieve the drowning lungs. So NIV is good when the person is having marked tachypnea, and it reduces the work of breathing, and it is a good tool to treat the pulmonary edema. We can go for the intubation if the person is having high stages like E, D, where the mentation is obtained, the patient is in much of the shock. Then we can intubate the patient. There is no clear-cut guidelines that this patient is intubated. This patient is getting intubated. There is no head-to-head trial of the intubation versus the NIV. The Hongsito et al. In 2017 published a data showing no difference in mortality in patients with cardiac shock who were randomized to either NIV or immediate intubation. So there should not be much hurry for getting the intubation. NIV is a good tool if the person saturation is maintaining on the NIV. HFNC is another good tool for those patients who does not tolerate NIV. HFNC works on the same manner. It gives the PEEP of around 7 mmHg, and this also is good for the pulmonary edema. Those patients who are not tolerating NIV. So when we keep the patient on the NIV, we should keep the CPAP on 5 to 10 centimeter of H2O. BiPAP, if we are putting on BiPAP, then IPAP should be 10 and EPAP should be 5. Target SpO2 is more than 92 only. Don't focus on the 100%. In clinical scenarios, if we talk about cardiogenic shock, let me tell you, it often confused with the COPD, acute exacerbation, COPD with sepsis. In those kind of things, this is very much confused. So make your target of SpO2 of not more than 92, 94. Avoid IPAP of more than 20 as it may cause aspiration and barotrauma. So intubation is classically indicated in those patients who have altered mental status, failure to improve after 30 minutes to 1 hour trial of NIV, they have vomiting or impending respiratory failure, the CO2 is quite high, or getting the hypercarbia and obtundation. Extreme acid base balance imbalance like pH of 7 less than 7.1, bicarb is 7, 8. In those cases, lactate is suppose 8, more than 10, then you can intubate them. So it decreases the work of breathing, and it put the rest to the heart and the lungs. So while intubating these patients, we have to take into account what inducting agent we are using, what other drugs, neuromuscular blocker we are using. Like for induction, we can use etomidate if it is preferable in patients who are having RV failure. The ketamine is increases the blood pressure and the heart rate, so it is preferable. And propofol is not preferable because it decreases the blood pressure further and heart rate. Neuromuscular blocker, Recoronam is a drug of choice, and it in dose of 1 milligram per kg body weight, increases the blood pressure and the heart rate. Succinylcholine decreases the blood pressure, and it should be, we have to check the potassium level too while giving the succinylcholine. Now, when we put the patient on the intubation, on the mechanical ventilation, two things we have to keep in mind. All the modes of the ventilator are good, either the volume control or the pressure control, but we should avoid the putting the patient on the SIMB mode, because when the when the patient trigger the respiration, those respirations are not supported by the ventilator. So the work of breathing is not decreased, and it further creates the problem to the patient. So what is our goal of PEEP? If it is a left-sided heart failure, it is 5 to 10. If it is right-sided heart failure, keep it little bit low, 3 to 5 mm. HFNC, as I have discussed, it is good for those who are anxious, who are not tolerating NIV, and this improve the oxygenation. We can give 60 liter per minute by this oxygen, and this can provide a PEEP of about 7 centimeter of H2O. It doesn't cause any effect of on hypercapnia, and it is not in hemodynamic in neutral. So as we say that NIV causes a little bit of the low blood pressure, it has some effect on the hemodynamic. It is hemodynamic effect, but it is not as much as NIV. Now, when we suspect of patient for cardiogenic shock, these are the few investigations along with the ultrasound, which we have already done with the rush protocol. We have to get arterial blood gas analysis, ECG. If the echo is available, we can do along with the ultrasound, KFT, LFT, anti-pro-BNP, and X-ray chest. Now, according to the etiology, we can identify what can cause the cardiogenic shock. The structural diseases like acute MR, ventricular septal rupture, free valve rupture, right ventricular infarct, or aortic dissection. So the above four things like acute MR, ventricular septal rupture, free valve rupture, right ventricular infarct. So these are the common complications of the common mechanical complications of the acute MI. They are most common found with the anterior valve MI. Although they are rare, the acute MR occur in less than 5%. Ventricular septal rupture is already less than 1 to 0.3 to 1%. So the incidence is less, but still they have a good number of patients of these. Aortic dissections and squeeze like acute MI, sepsis, myocarditis, medication toxicity, unstable dysrhythmias. These are the conditions which can affect the myocardial contractility. Stop is like obstructive cardiogenic shock, like AS, severe MS, hypertrophic obstructive cardiomyopathy, left atrial myxoma, pericardial tamponade. All these are the causes of obstructive cardiogenic shock. So have a quick look on the structural causes, acute MR, acute AR. In the acute MR, what we will find that the person is who suffered from the MI, get the holosystolic murmur, usually at the apex, and it worsen on the straining, and it needs to increase the afterload. Acute AR, there is a high pitched blowing diastolic murmur, loudest at the third or fourth intercostal space in the aortic area. The ventricular septal rupture, you can find a new holosystolic murmur. So now you can see here the holosystolic murmur occur in the acute MR also and the ventricular septal rupture also. But acute MR is, first of all, it is more common than the ventricular septal rupture, and the ventricular septal rupture, the holosystolic sound you will get in the left side, in the around the third intercostal space, and while in the MR it is found in the apex. So these both are the needs the decrease the afterload. The ventricular septal rupture need the decrease the afterload. We have to give the vasodilator. We will discuss in next few slides. Now, free valve rupture. It is a rare complication of the MI. It can cause tamponade and in this condition, if we suspect do not pericardiocentesis, do in the ED, we have to take the patient into the cath lab or in the CCU, and then only we should proceed with it. It needs urgent surgery. RV failure caused by RV infarct, massive pulmonary embolism. So the treatment is optimized preload, aggressive control of hypoxemia, acidemia, and hypercapnia. Aortic dissection type 1 is mostly associated with the cardiogenic shock. The goal of SBP is 100 to 120 mmHg, goal of heart rate is 60, and pain control. Now, pharmacological treatment. So, diuretic are the treatment if the person is having pulmonary edema with the cardiogenic shock. Otherwise, they doesn't have any treatment. That doesn't have any role. But most of the time, the cardiogenic shock is associated with the pulmonary edema. That is why I have just little mentioned about it. Now let's concentrate on the cardiogenic shock. There are the few drugs like inopressors. These are the first line important drugs like norepinephrine, epinephrine, and dopamine. Norepinephrine work on the alpha 1 and beta 2 receptors. This is given in the doses of 0.05 to 1 milligram per kg body weight per minute. It increases the systemic vascular resistance. It further by increases blood pressure and cardiac output and heart rate. The epinephrine increase work on acts on the beta 1 and the alpha 1 and beta 2 receptors. So it is mostly act on beta 1, and the dose is 0.01 to zero point 0.5 milligram per kg body weight per minute, and it has similar action as noradrenaline, but it is little bit more arrhythmogenic. It causes more increase in the high blood pressure, and it increases the it increases the more heart rate. Dopamine, it acts on the beta D1 receptor, dopamine receptors, and beta 1 receptors and alpha 1. It causes different actions on different doses, as we know, and but ultimately it causes, most of the time it causes the increase in the systemic vascular resistance and blood pressure. But it is among these three, the dopamine is the most arrhythmogenic drug. That is why nowadays it is not advisable to give dopamine as a inopressor. Inodilators. So these are the drugs which dilates the peripheral, decreases the peripheral vascular resistance, systemic vascular resistance, and increases the cardiac pumping. So it acts on the beta 1 receptors and beta 2 receptors. Dopamine is given 2 to 10 milligram per kg per minute. Milirinon, that is a vasodilators 3 inhibitors. These are given in the 0.25 to 0.5 milligram per kg per minute. These have, both the drugs have similar actions. Now, vasopressors like phenylephrine and vasopressin. Phenylephrine acts on alpha 1 receptors, and it is given in the dose of 0.1 to 10 milligram per kg body weight per minute. It increases the systemic vascular resistance, it increases the blood pressure, and it decreases the cardiac output and heart rate. Vasopressin act on vasopressin receptor, given in the dose of 0.01 to 0.04 unit per minute. It increases the systemic vascular resistance, increases the blood pressure, it decreases the cardiac output. Vasodilators like nitroprusside and NTG, it is given in the dose of 0.3 to 10 milligram per kg per minute. It decreases the SVR and blood pressure, and it increases the cardiac output and heart rate. NTG same, it acts on the converts to the nitric oxide, and it decreases the systemic vascular resistance and increases the cardiac output. Inotropes like isoprotrenol and dopamine, isoprotrenol act on beta 1 and beta 2 receptors. It decreases the systemic vascular resistance, No effect on the blood pressure, increase the cardiac output and heart rate. Levosimendan. Levosimendan is mostly used in the pediatric age group of patients, mostly in the myocarditis. It is a good effect on the pediatrics. It acts on the dose of, it's given in the dose of 0.05 to 0.2 milligram per kg body weight per minute. It decreases the systemic vascular resistance, decreases the blood pressure, it increases the cardiac output. Now, a word about the common mechanical cardiogenic devices. Mechanical cardiac devices. So there are the various type of mechanical cardiac devices like Impella, IABP. There are different type of Impella devices like CP and 5.5. There are the various artery to venous, venous to artery. So these devices had having class 2A indication in use for cardiogenic shock by AHA 2022 and similarly by the European Society of Cardiology in 2021. They don't have any long-term survival benefit. The IABP shock 2 study comparing IABP with mechanical cardiac s- 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 devices like Impella shows no significant difference in mortality. No proof of one device better than the other. It's patient selection and local expertise which device type, which decides that device to be used. So in Germany it is Impella and in France it is ECMO. So how it acts, you can see here that this the balloon of the IABP has been uh, is taken from the femoral artery to the aorta, femoral artery to the aorta, and it is distal to the subclavian branch. When the subclavian is out from the aorta, it is put distal to the subclavian, from where the subclavian emerges from the aorta. Now, when the you can see here that when the balloon inflates when the aortic valve closes, and it deflate when the that aortic valve opens. So it gives the time for coronaries to give the blood to the coronaries, and it increases the contractility of the heart. Now, the common complications of these devices are limb ischemia, septicemia, balloon rupture, peripheral neuropathy, and pseudoaneurysm and fever. Bleeding in ischemia is more common in Impella, and hemolysis is classically more common in the Impella devices. Now, a little few words about the ECMO, which is more common in the nowadays. It is a preferred method for mechanical support in cases of cardiogenic shock associated with respiratory failure. It provides full biventricular support and support oxygenation and carbon dioxide removal. Major complications are major bleeding, sepsis, limb ischemia, lower extremity compartment syndrome, stroke, and lower limb amputation. Retrograde flow in the aorta causes the increase in the LV afterload and acute pulmonary edema. The solution is combining IABP or Impella catheter with the ECMO to reduce the LV afterload and draining the blood from LV to reduce end diastolic pressure, known as venting. So here we can show diagrammatically that the blood is taken from the femoral vein, it goes to an oxygenating membrane, and that the oxygenated blood goes from the to the femoral artery. It is the veno-arterial ECMO. To deal with the cardiogenic shock, we have various level of the ICU and the emergency teams. In the we can see there are three levels: level 1, 2, and 3. So in the level 1, the all aspect of the cardiogenic shocks are seen in the CCU and the PSC. Advanced percutaneous or surgical mechanical devices, uh, cardiac devices are available. On-site specialists are available. May have durable left ventricular devices, assist devices, and heart transplant capabilities. Level 2 can do STMI or PCI capable centers with those having mechanical mechanical devices, cardiac catheterization laboratory, intensive care units, and hemodynamic monitoring. They can do IABP or LVAD, and on-site specialist availability is interventional cardiology or general cardiology. In the level 3, these are usually found in these are the mostly available in the India. The centers capable of initial diagnosis of the cardiogenic shock, not PCI or the mechanical device capable. They have intensive care, on-site specialists or general cardiology consultation is only available. So as the level advances, in the level as the level advances from level 3 to 2 to 1, the more and more specialists are available, and the on-site interventions are available for the cardiogenic shock patients. So in a nutshell, what we can see that cardiogenic shock is an important day-to-day uh, diagnosis which we do, and while treating the patients, most of them require inotropic agents. And along with this, when we have to see the other things also, not only that person is having cardiogenic shock, that they can have pulmonary edema along with it, they can have COPD along with it, they can have diabetes and the hypertensive heart disease along with it, pericardial tamponade. There are various causes of cardiogenic shock, and there are various things which we have to look once when we are treating with the those cardiogenic shock patients. So I think I have explained it. Is there any question?
Sir, very, very candid talk, sir. Very lucid explanation, sir. Thank you so much for sharing your thoughts on this, sir. So, we have any questions? We'll take, sir.
I think there is no question, Dr. Prashad. Then we can wind up.
Yes, sir. Yes, sir. Thank you so much for spending your valuable time with us, sir. Thank you so much.
Yeah, thank you. Thank you. Thank you.